So just to give you a little bit of who I am, my name is Christina Magel. I am a registered nurse. My background is emergency nursing. I was an ER nurse for 12 years. And then a year ago, I became certified as a wound and ostomy nurse. So I currently work at Frederick and Community Memorial on the inpatient wound and ostomy team. But I also teach for them. I teach the trauma nurse core curriculum, and I'm ACLS faculty. And I teach that for both Frederick and Aurora. So like Mark, I have one of these schedules. It's who am I today and where am I working? And then I was recently hired to be part of the faculty at Alverno College on their nursing program. So I'll be starting that this fall. So again, a little bit of everything everywhere. But I've stayed connected to the emergency nursing, the emergency medicine world through teaching, and I'm certified, national certified since 2001, and have maintained that certification as well. So, well, we have the morning together. Mark has informed me. So we are going to start with anybody have a great love and passion for endocrine? I don't, little bit of a hand. I know it's one of those really tough specialties because it's not outwardly obvious as to what's going on with the person, and it really requires a significant skill in that physical assessment and history gathering to start to put the puzzle pieces together. So I know you guys are all experienced. You all have a great book, and when I put together the talk for this morning, I really wanted to focus on case studies because I think real patient scenarios really bring this stuff to life and can paint the picture for us of how you can have true endocrine emergencies. We all know people who are diabetic, right? Some extended maybe a family member, extended family, friends, whatnot. And there are a lot of people that manage their diabetes well and never end up in these situations. But then we're going to have some undiagnosed endocrine situation going on. You're going to have that undiagnosed diabetic who is near the brink of coma or in a coma related, and we need to know how to respond to them. So that's where we're going to start, if that's all right with you. All right, since we are doing a case study format, what I would like to do is I'm going to pass out an assessment worksheet. There are 8 case studies altogether, so on the front and the back of this worksheet, there are columns for you to jot down data about these patients as we go through the assessment of them. Let's jump in. Any questions right off the bat? All right, so in your textbook, of course, these are all the different endocrine emergencies that are listed as important to have knowledge of. So they're divided up. We've got all the different types of diabetes and complications that can be associated with those. We've got then the pituitary problems, things related to either pituitary hormones that are going crazy from the pituitary gland itself, or what I see in radiology is a fair number of people who have tumors, say in their lungs, that actually secrete neurohormones and cause a great deal of problems. So we'll look at those. Adrenals. Those are always mystery ones. That's where our epinephrine comes from and our mineral corticosteroids. So lots of problems with people with adrenal issues. Thyroid. Thyroid has a great deal of impact on the cardiac system. So we'll look at the impact on the heart, and you can kind of start to put that together. You've got somebody who's got some cardiac issues. Well, maybe they've got a little thyroid crisis going on at the same time. So objectives, always have to put those in there to be a good educator, right? So really the whole point is to use these case studies to explore some of these endocrine disorders in hopefully an interesting way, because it is a tougher subject. Use assessment to start to narrow down what the problems could be. Look at each of those endocrine systems a little bit, talk about that pathophysiology, and then identify those therapies that that patient needs, either pre-hospital or what you can anticipate once they get to definitive medical care. All right, so let's look at case number 1. 911 call comes in. We've got mom, a little bit hysterical on the phone. She says her 6-year-old son is not responding to her. And she's hysterical. She's got the help me going on the call. So we're working with a good dispatcher. They alert you to the call, send the message out to your rig, and works to get a little bit more information from the mom. What we find out is that mom says her son has been ill For the last 24 hours, he's been very fatigued, tired, just not his normal energy level, which is unusual for him. He's had vomiting, abdominal pain, and the dispatcher is also able to ascertain that mom thinks that he's had a lot of increased thirst, and she notices him running in and out, coming in from playing outside and running to the bathroom all the time. She wasn't quite sure what he was doing in there, but she knows he's been in the bathroom more than usual. Also been eating everything in sight. And she just attributed that to being a growing boy. That's that initial information we have. Past medical history? None. Full term at birth, no complications. Does seem slightly small for the age when you arrive and you first get that first eyeball look at the size of this kid. No meds, no allergies that we're aware of. So where do you guys start? You arrive on scene. What are you going to do with that kid first? Okay, so we just start with that. We're walking in the room and we do the across the room assessment, right? As we're approaching him, we're already trying to figure out what's going on. So when you're looking at him, what are you looking for? Is he breathing? Yes, he's breathing. What's that? Yeah, how much effort does he have? And he has, in his respiratory effort, he is breathing. He has decent color, but he has forced breathing with a longer expiratory phase than an inspiratory phase. What else do you want to know? Mental status, he is not responding to. Longer expiratory than inspiratory phase. What else would you like? Color. Pale to normal, but no cyanosis. He has very poor skin turgor. Blood sugar. Ah, what a great question. Blood sugar is 420. All right, here's our vitals. So he's running 75 over 40. He's a 6-year-old kid. Do we know if that's good for a 6-year-old kid? What's our pediatric formula? Did anybody know this? So 2 times what? Okay, so 2 times their age plus 70 is your baseline for the lower 5th percentile of where our pediatric blood pressure should be. So he's 6 years old. 2 times 6 is 12, plus 70. So he should be at least 82, right? So how do we feel about this blood pressure? Yeah, he's lower than he should be, okay? Not critical, but he's lower. We've got pulse 150 for a 6-year-old. Where is that? It is too high. It is tacky. So he's showing some tachycardia. Respiratory rate. How do you feel about that? It is too high. So again, and we've got that forced expiratory phase. Oh, what a great question. Yes, it's very fruity. Very fruity breath. What else would you like to know? Great question. There is grandmother on mom's side and an uncle have diabetes type 1. What other systems do you have in front of you that you want information on? Yeah, mom has seen him going in and out of the bathroom quite frequently, so we can maybe make a presumption there. Yes, he does. Polydipsia, polyuria, and polyphagia. You asked about his skin, so it was poor turgor, pale. He responds to pain. So he's kind of moaning, but really doesn't open his eyes on command. So what do you guys suspect? You've got a pretty good picture. Okay, so sounds like we've got likely the diabetic ketoacidosis going on. What's happening physiologically in his system? Okay, so what does it have too much of? So it has too much sugar. And when you have not enough insulin, so that's type 1 diabetes, correct? So if you don't have enough insulin, the sugar accumulates, and we end up with these high sugars everywhere. So what does the body use for an energy source if it can't utilize the sugar that it's got? Ketones are the byproduct, right? So fat. So right, the body is mobilizing those fat stores. It's a very, let's see, ineffective. It's energy inefficient to metabolize fat. So ketones are the byproduct of the fat metabolism. But the body's trying to get energy from somewhere, and that's how it's generating. So with a byproduct of ketones, what happens to their metabolic state? Yes, too much acid. So we have those fatty acids, so they're acidotic. Is it a metabolic acidosis or a respiratory? Yeah, it's the metabolic acidosis. So what would we expect if we, now do you guys have the ability to do labs or blood gases on a rig? Forgive me, because I've not worked in your shoes, so I may have paramedic questions, and you can educate me just like I'm sharing with you. So, all right, but once we get to the ER, if we're able to do blood gases, what would we anticipate those to be? What might that pH run? Yeah, it's going to be low. So what's our normal pH range? 7.35 to 7.45. So it's not unusual for these pHs to be less than 7.3. Very common to have that derangement. What about bicarb? What's the body doing with the bicarb supply? Yes, we are consuming it because it's trying to balance out the acid. Bicarb is a base. So they're reacting with each other, and the bicarb stores are being used up. So all of these questions are important because they're all going to lead to how we're going to take care of this kid. All right, so here's a nice complicated little diagram about DKA. Whenever I see one of these in a textbook, let me share with you how I start, because I'm also a student. I'm working on my Master's of Science in Nursing at Alverno to be an NP. So my pathophysiology book has lots of these kinds of diagrams. And the way I tackle them is start at the top, see what we're dealing with. So we're trying to chew on DKA and what it's all about. And it's telling us that we're trying to figure out metabolically what's going on with that absolute insulin deficiency in that type 1 diabetic. Then I'll look at the bottom. So the bottom is the outcome that our patient is experiencing. So diabetic coma, that's where this kid is at, right? And all of that junk in between on that complex chart, of course, then helps us break down what's going on system by system so we can understand that pathophysiology of that disease. So we talked about the cells are not able to use glucose. So we've got this glucose usually over 300. That's kind of a diagnostic criteria for type 1 diabetics and DKA. If we were able to do a urine dip, would we see a little bit of glucose in that urine? Absolutely. We know about the polyuria. What signs do we have that the kid is dehydrated in our physical assessment? Turgor. Yep, blood pressure is low. Tachycardia, right? So heart rate's up. So we've got lots of signs telling us that yes, he's probably dehydrated. He's been losing potassium and sodium as he pees it all out. All those electrolytes right down the toilet, literally. So we've got low volume, increased heart rate, and then we talked about breakdown of body proteins, trying to get that glucose level up. We have the breakdown in the fatty tissue and the generation of the ketones. So here's the criteria for diagnosing DKA. We've got the blood glucose levels, by definition, are greater than 250. The serum bicarb, when it's finally measured, is going to be less than 15. Does anyone know the normal range for sodium bicarb? 22 to 28, absolutely, good job. pH is low, so we talked about that, less than 7.3. And then ketonemia is the ketones in the blood, so we will draw that lab when they arrive, as well as get that urine and check for ketones there. So these are the diagnostics we'll use. So what are our goals? This kid needs some IV fluids. Yes, we need to improve his volume because he has been losing, and he's dry as a bone. So we want to get volume and get that tissue reperfused. We need to bring down that glucose. But do we want to bring it down super fast? If we gave a whole boatload of insulin and that blood sugar plummeted, what could we do? Do you know the complication? This is where I like to draw. I hope you guys don't mind. I like pictures. I'm very visual. All right, let me find a marker that works better. All right, so this is, if this is intravascular. Oh, I can't spell on the board here. Okay, vascular. And here's our extracellular, our extra outside compartment. When we have high blood sugar, where's the glucose? It's intravascular, right? It's outside the cell, so it'd be a lot of glucose in here. So very high concentration of glucose. So if you know the concepts around osmotic or oncotic pressure, when you have more, like a higher oncotic pressure or more solutes in one area, what happens to the water? Right, it moves away. So if I think, oh, I'm going to give a whole bunch of insulin and I'm going to lower this blood sugar and fix this kid, because that's the problem, right? Now I'm going to take away a whole lot of this sugar that's floating around. And where's that water going to go? It's going to go back. So initially it went out, now it's going to go back. What if these are brain cells? What if these brain cells are all of a sudden filling with a lot of fluid? Because I lowered the sugar too quick, the oncotic pressure didn't balance out. Right, so I'm going to end up with cerebral edema. So that's a critical thing that we need to avoid. We're going to give fluids, but we're going to give it at a managed rate. So initially, they'll for a 6-year-old kid, what's our formula for fluid resuscitation? 20 mils per kilogram. You got it. So we're going to start there, a couple of those boluses, reassess, and go from there. So they're going to get insulin. It'll be a low-dose therapy, and they will likely end up on an insulin drip in a pediatric ICU eventually, ideally. The good news is, because this disorder is so well understood and so well studied, that when treated properly, the mortality rate has really come down to less than 5% as far as the epidemiology goes. Questions? DKA. We started with an obvious one. Endocrine only gets more complex after this. All right, so DKA goes at the top of your column. Let's begin case number 2. All right, so another 911 call. We have the girlfriend calling in this time. 56-year-old male patient. She says, my boyfriend isn't acting right. He's been sick for 3 days. Now he's not making any sense at all as he tries to talk to her. She thinks something's wrong. Dispatcher gets a few more details. Girlfriend says he's been kind of weak, just laying around on the couch for the past 3 days. That's not like him. He usually goes to work. He is urinating a lot and he's drinking a lot. Not beer. He's drinking lots of water. Water and Gatorade he's been craving. Today, she thinks, before he became kind of this obtunded or not responding to her well, that he's seeing things that aren't really there. He's talking a lot about snakes on the walls. Past medical history. She tells you that he is a diabetic type 2. He's had this for 10 years. He's got a hypertension. Oh, they don't check blood sugars in the house. Also a history of hypertension. He is, quote unquote, diet controlled for his diabetic. He also has a BMI. Did I put that up here? No. He has a BMI of 42. So what's our normal BMI range? To be 20 to 25 would be ideal. 25 to 30 BMI is overweight. Over 30 is obese, and then over 40 is morbidly obese. So he's 42 BMI of 42. He's on metformin and hydrochlorothiazide, usually. No allergies to meds. So that's our initial call. All right, let's begin our assessment. What do you want to know?
His mentation.
Okay, mentation is, he's not really talking. You see a lot of twitching all over his body. So you're on site now. You see a lot of muscle twitching, a lot of muscle fasciculations going on. They really won't answer your questions at all. What was that, Rachel? Okay, let's get some vitals. So we've got 95 over 40, pulse 135, respiratory rate is 20. Look at that temp, he's 102.9, and pulse ox 97%. Blood sugar you asked for, 850. Yeah, how high does your monitor go? 500, 600, yeah. But I think ours in our lab, ours goes up to 500. So we'll figure that we'll get this number, definitively when we can send it to the actual hospital lab. It is a wee bit high. Just for kicks and giggles, what is the normal blood sugar range? Yeah, it's somewhere. I kind of. Every book has a little bit of a different range, and every lab has a different range. So it's approximately 60 to 100 or 105, somewhere in there. So yeah, this is a little bit out of range. So yes, your monitor would just read high. All right, what else do you want to know?
How long has he been sick for?
Okay, 3 days, girlfriend says. Just feeling really weak. Has called in sick to work. He is a construction worker, and he hasn't gone to work.
What was the temp of 102? I would ask the question, if it's still high in his blood sugar, when he's urinating, does it smell foul? So is his blood sugar?
Okay, she wants to know if there is a small, foul-smelling urine. There's a lot of urine, but there is no foul smell to it. Good question. Breath sounds. He has normal respiratory pattern and effort. Respiratory rate, 20. No increased work of breathing at all. He's on metformin. And the girlfriend tells you he hasn't had it filled for 3 weeks.
Any wounds?
Oh, what a great question. You really want to take those work boots off? Yes, he does smell like he has some little pseudomonas in the feet going on. All right, so normal respiratory pattern. We noticed the increased rate. It's a sinus tach. Got him on the monitor. You can see that he's sinus tachycardia, no arrhythmias. He's got the P's, polydipsia, polyuria, polyphagia, according to the girlfriend. Skin turgor is poor. We didn't ask that question, so showing signs of dehydration again. He's aphasic currently. We see the muscle twitching. He's got the hyperthermia, which can be a neurological issue, potentially, and the hallucinations as reported by our girlfriend. All right, so I heard a suspicion. What do you think's going on? So hyperosmolar, hyperglycemic, non-ketotic coma, or syndrome, depending on which textbook you're reading. So sometimes it's HHS, sometimes it's HHNK. Terminology varies. I agree with you. So what's the difference between this disorder and diabetes type 1 with DKA? Okay, so it happens to non-insulin dependent peeps.
Something else underlying going on.
Yes, okay, so the wound connection, yep, we've got that lovely pseudomonas smell. So something is triggering this in his system. Something is triggering. What's the physiologic problem with type 2 diabetics? Do they make insulin? Correct, yes. So the cells can't utilize the insulin for whatever reason. He's making it, he's just not using it. So it's interesting because they start to pour, with that polyuria, they start to pour the glucose into their urine. So when we do that urine dip, finally, we'll see lots and lots of glucose. But as that sugar continues to climb and climb and climb, then the kidneys start to be affected and they start to go into acute renal failure. So now they can't put out the glucose, and it's just this vicious cycle. That's why these sugars are so much higher, usually, than the patients who are in DKA, because that vicious cycle just keeps making it climb and climb and climb. So HHNK, here's another lovely diagram. So you were right. Environment, infection, or emotional stressor. Something triggers this. And he's got the wounds on his feet. He needs to come see me in the wound clinic. Actually, he needs to see me in the hospital. Yes, so he's got significant issues. He has decreased amount of insulin, so we have little breakdown of fat in the cells. So the body is metabolizing differently than it does in DKA. So we don't have the ketone bodies here that we would expect in type 1. The liver is breaking down glycogen to glucose, leading to that hyperglycemia. So that's, again, one of those contributing factors to that blood sugar that's climbing so high. Initially, you get the osmotic diuresis through the polyuria until you end up with the renal insufficiency, and then the kidneys can't put out the sugar anymore. They also end up with hypokalemia. So he needs his potassium level checked sooner than later, because as they are spilling out all of that sugar, with it goes quite a bit of the potassium. So they can end up shocky and in cardiac arrhythmias as a result. So here's the definitive diagnostic criteria for the HHNK or HHS. Blood glucose levels greater than 600. When they measure the plasma osmolarity, again, what is that measuring? What does that lab test measure? Yeah, you're on the right track. It's a concentration of the solutes in the blood. So proteins, any type of molecule that has the ability to affect where water goes. So that exerts an osmotic effect on cells or extracellular. Hello. So plasma osmolarity is measured, and it's greater than 320, meaning he's got a whole lot of stuff in there, in this case sugar, that's creating this dehydrating effect. So it pulls fluid again from the cells into the vascular system, and then the urinary system pees it out. So what's the state of their general cells out in the periphery? If you test skin turgor, what's it going to feel like? Yeah, they're going to be very poor skin turgor. So again, they're going to be very, very dry. So we have no ketoacidosis, so that's a major differentiating criteria. So the lack of the fruity breath would be a key assessment, and the lack of the normal respiratory status is a big clue too. And then depression of the sensorium. Hallucinations are very common. So this guy's seeing snakes on the walls, the electrolyte imbalance, and the hyperglycemia is causing more nerve transmission as a result. If you ask me to explain the exact biochemistry, I will not be able to. But it's a great question. All good questions. Any other questions or comments on him? No? Okay. So good job with the diagnosis. How are we going to treat him? We're going to, again, he needs volume, just like the kid did. So we need to improve volume and tissue perfusion. We need to bring that glucose down. We need to fix the potassium. Very, very careful. You know, he probably bought himself an admission to an ICU bed in most facilities. And then cerebral edema here can be another major complication of rehydration. So slow and low leveling or correction of that blood sugar. So we're going to do low dose therapy again, IV fluids. And this one does have a much higher mortality, especially when you think about that there's usually an underlying cause that's triggering this. So he's got this infection he's dealing with, wounds that won't heal. His body's in a world of hurt right now. You'll usually, like what our practice in the ER, what I would usually see the ER providers do is order somewhere like an 8 to 10 units of regular insulin, and then we would start the insulin drip, again at a lower rate, and then they get Q1 hour glucose checks with, you're talking to the provider, how do you want this adjusted based on, so it's a very controlled lowering. It is going to take a long time, but the goal is not to cause this cerebral edema. So we do want it to lower. The body has adapted over time because he hasn't had his drugs for 3 weeks. This sugar's been climbing and climbing and climbing for much more than 3 days. He's only felt sick for 3 days. So we have to bring it down low and slow so the body can adapt. His therapy in the ER, what I would anticipate would be the insulin as we discussed. He's going to get IV fluids that are going to have a potassium supplementation to them. So it's going to be like a normal saline with 20 kcal added in his liter bag at a controlled rate. He is going to get, the doc's going to see right away that lovely Pseudomonas. So we're going to get cultures, blood cultures, and we're going to get IV antibiotics on board.
Those antibiotics are not going to affect his slow insulin drip treatment?
It shouldn't. Probably he'll end up with different IVs. So he'll have to have 2 IV sites dedicated for an insulin. And I had an interesting experience at Waukesha. I had the opportunity to, be part of a root cause analysis. Are you guys familiar with that term, root cause analysis? So something goes wrong, and you come together as a team to try and figure out what process went wrong and why the patient didn't get the ideal treatment. So it was a DKA patient that ended up on an insulin drip that was sent to the ICU. And do you guys use pumps on your rigs, or is everything open? You have a pump? Okay, so there are some pumps, some are free hang. Okay, so pumps are really a gift to bedside care providers, because they allow us a lot of control. But they also can cause problems if not used properly. So what happened with this DKA patient is the insulin drip was mixed, primed, and hung as a secondary infusion. So you've got your primary bag plugged into the pump with a rate, say it's a rate of 100. Then the staff hung the insulin as a piggyback into that, programmed it to do so many units for a certain period of time, and when that time was up, it switched back over to primary. The patient went without their insulin for 6 hours before it was discovered. So safety, if running an insulin drip, what we learned and how the policy was changed, that it needs to be on a primary line. It can never be a secondary infusion. And that might not have, until something like that happens, you might not even think about it to that level of detail. So the patient was fine. They corrected it, but it was again 6 hours that they needed insulin that they didn't get it. All right, so I just pulled this table out of one of our pathophysiology books, really to kind of compare the two, just to show those differences, reiterate between the DKA and then the hyperosmolar non-ketotic hyperglycemia. So you can see that the NKH or the NNK, again, however you want to, HHS, whatever you want to call it, glucose much higher than the glucose in DKA. You can see it's type 1 versus type 2 usually. DKA has that precipitating event. Fluid losses, this particular book addressed the fluid losses. You can see how much fluid the body does lose. The HHNK tends to be a drier patient than the DKA. Clinical presentation, our little kiddo had all of those symptoms. The older adult was certainly approaching that with his aphasia and his neurological status. Higher mortality rate reported in this source. Treatment, insulin, saline, potassium, and then complications we all discussed. So just kind of a nice side-by-side showing the differences. All right, ready for case 3? All right, you're sitting in the classroom listening to an absolutely riveting talk on endocrine emergencies. You hear a thud in a nearby seat and see a classmate slumped over a table. Before coming to the conclusion that he is just bored and or tired, you also notice that he is profusely diaphoretic to your touch and clammy. So where are we going to start? Excellent. Let's call for help because we don't have, I don't know if we want to trust any of the resources in the room here. They're education resources for a reason. Okay, yes, they are breathing. Do we not? What's their breathing rate? Their respiratory rate is 26. No, I'm sorry, 18. 18. So of course it's a friend, it's a colleague in the classroom. We don't know jack diddly about their background, right? So we don't know past medical history. We don't know meds. We don't know allergies. We dialed 911. You guys did that. All right.
Very limited resources we have.
Yes, exactly. So we have to completely rely on our physical assessment skills, right? So let's physically assess them while we're waiting for our 911 compatriots to arrive. Oh, it's bouncing. Look at that. All right. So we grab a blood pressure cuff from the room. We get 120 over 75. Someone's palpating his pulse, and we feel it counting about 125. Respiratory rate is 18. Temperature 97.9, and we use the red probe just for the record, okay? And pulse oximetry 98%. So any concerns in the immediate vitals? Okay, so he's got the tachycardia, but everything else is pretty okay. All right, so what else do we want to look at? Haha, blood sugar. So we pull out our handy dandy practice blood sugar machine and we get 26.
So was this person like having all this on their desk?
They came in late with a cup of coffee in their hand. He was complaining, you heard him complaining about how hungry he was because he had to skip breakfast. He does respond to painful stimuli, yes. Diaphoretic, skin turgor is normal. He has a bracelet that says he is a type 2 diabetic. So what do you guys suspect? You know, hypoglycemia. All right, so we've got hypoglycemia. All right, so by definition, it's a glucose less than 60, but people start to have symptoms at all different ranges, right? Everybody is very unique, very unique. When I had a case in radiology, we were doing an angiogram on an older gentleman's leg. We finished the angiogram, moved him from the procedure table back to the stretcher, and all of a sudden he's slumped over with a facial droop, drooling and not responding to us. Well, we're in radiology. What do we automatically start to think? Stroke, and where do we go? Because we're in radiology. Straight to CT, right? We're going to be like super CT people. We did, until he was halfway through his CT, and it was 27. We just spent $4,000 to fix a 50-cent problem. So yes, blood sugar, crucial to check. All right, so treatment options. These are the general guidelines. Again, and it's going to vary by protocol, by patho book. Our goal is, if they're awake, what's your criteria for giving oral glucose? Okay, all right. So is he doing that too well, slumped over the table? All right, so we have to skip the 50 to 20 grams of oral glucose in this particular individual. Glucagon, IM. What's that? Intranasal. Got that option, that's fantastic. So that's an option, if we've got that. Or if we start that IV, we're gonna do that bolus. And when I started nursing, back in 99 was my graduation date. So initially we would always push that entire amp of D50. Now they're getting a little bit more selective with how much we start with. Are you guys seeing that too? Yeah, give a half amp instead because we're causing them to rebound so far in the other direction. We're forcing hyperglycemia on them, which is also not good. So the range is 20 to 50 milliliters of that 50%, that D5 dub. All right, so our classmate wakes up, gets his sugar. And you learn that he's a newly diagnosed type 2 diabetic with a recent change in diabetic medications. So they've been monkeying around, trying to get them. He's running late this morning and consumed nothing besides 2 cups of coffee, but he did take his meds. So here we had a little bottoming out, some hypoglycemia. In doing the review for this class, when I was reading about hypoglycemia, there are people, now have you known people who can feel when they're getting low blood sugar? There are people that cannot detect it. So they might be dropping 60, 50, 40, and they have absolutely no indication, symptom-wise, that they're dropping until they pass out. So it's just so crucial to remember everybody is such a different individual when we're dealing with these. Questions on hypoglycemia? All right, case 4. All right, we have a 35-year-old female discharged from the hospital 2 days ago. She had neurosurgery. They took out a benign growth from her posterior pituitary gland. She has called 911 because she is profoundly weak and she's having profuse urination. I just can't stop peeing and drinking. I have no one at home to bring me to the hospital. Help me. That's what she says. Okay, so you're dispatched to her home. You find no other past medical history other than this benign tumor that was, she says it was found as an incidental finding on CT after she had a bicycle crash and she hit her head. So they did a CT as a precaution and they found this tumor. No meds, no allergies currently other than some pain medication maybe for a headache. So where are we going? She was diagnosed with a concussion. No bleed. No bleed. They just said, take it easy, you have concussive syndrome. She was told that it might last. She might have some symptoms for 3 to 6 months, but no long-term effects expected. All right, so what else do we want to do in the home right there? What other information can we gather? Okay, good. All right, so vitals. 110/65, pulse 98, respiratory rate 16, temperature 98.9, pulse oximetry 98%. How do you like those vitals? I'm pretty cool with them. I think they're good. All right, what else should we check? What can we do right there in our home before we transport her? Blood sugar, 95. Nothing jumping out at us just yet. Okay, let's get a 12 lead. Normal sinus rhythm. Respiratory, you can see up there. Yeah. Yes, there is something going on. Is it Pete? No, Paul, sorry. I had the P. Paul's on the right track. He asked about vasopressin. Vasopressin. Something, what's the other name for vasopressin? Antidiuretic hormone. Yes. So in someone whose pituitary is functioning normally, what does antidiuretic hormone do for us? Right. So if you have a normal amount, yes. So the higher it is, the more water retention you have. So if it goes the other direction, what happens? All right, so now you're going to start, if you don't have any to hold the water in your body, now you start emptying it out. So which way is she going, does it sound like? Okay, so probably low. So your anticipation that she has a low ADH level is right on target. So in that GI-GU system, we know she's polyuric. She's also been profoundly thirsty, trying to keep up with it. She's going to the bathroom every 10 to 20 minutes, drinking water constantly. Otherwise, no other GI-GU symptoms. What else are we assessing? Skin. Okay. Skin turgor, warm and dry. At this time. Could change. Neurostatus, she's appropriate. Totally appropriate. Answers all questions appropriately. So essentially within normal limits. Little fatigued. All right, so what do you guys suspect? So we talked about ADH, too low of an ADH. There is a condition that causes too low of an of ADH. Does anybody remember the name of the condition? I hate the name of it because I always confuse it with the first three that we've already talked about. Here's a clue. Oh, I already talked about it. Okay, so here, again, just a diagram looking at the pituitary gland. So we've got the posterior pituitary that puts out the ADH. It's also responsible for other hormones as well, but we've got that failure of that water reabsorption. Okay, there it is. There it is. Diabetes insipidus. Diabetes insipidus. That's why it's so confusing, because when you hear diabetes, what do you think? Sugar, 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 right? I have not come across a medical emergency related to too much or too little oxytocin. So that's out of my scope of knowledge, to be honest. Yeah. Yeah, I think you'd have to spelunk into some deep GYN or endocrine texts to find more about that. But it's a reasonable question. So diabetes insipidus is not about sugar. It's all about the ADH. So this is one of those little things that you got pounded into your head. So we have a deficiency or decreased response to ADH. Look at that, liters of urine daily, 3 to 20. That is a lot of fluid. You are peeing your mind out. There goes your quality of life. You're in the bathroom all the time. Lots and lots of thirst. Now, she's been able to keep up for the most part. If you are able to take in as much as you're putting out, there will be very little symptoms, as evidenced by her vitals, right? She's not tacky. Skin turgor's okay right now. She seems to be compensating with her drinking. If the patient then becomes compromised, let's say that they're not able to take in the fluids, this is where we start to get in trouble. Because now they're going to get that profound dehydration because they're not taking in what they need to. So how do they diagnose it? Unfortunately, we can't just measure a plain old vasopressin or ADH level. That lab test doesn't exist. So the diagnostic process for this is they're going to have a 24-hour urine measurement looking for what's the hormone that stimulates the pituitary gland. Where does it come from? Yeah, it comes from the hypothalamus. So we're looking at adrenocorticotropin, ACTH hormone. So they're going to do some ACTH levels. Looking at the output of the hormone over a 24-hour period of time in the urine. We also need to make sure that we don't have the glucose issues, so they're going to do glucose studies as well, make sure that there's no other signs of diabetes. They need to check for renal dysfunction. And treatment for this is very conservative. So again, they're going to look at that cause as to why. You know, we kind of know why, right? Her posterior pituitary was recently impacted by the trauma of surgery. They're going to watch her over time. The DDAVP is a substitute vasopressin drug that can be given, but it's not a first-line treatment. They're going to evaluate, they're going to do all the diagnostics, make sure that the fluid balance is obtained, and go from there. All right, 4 more case studies will get us through the endocrine. So flipping to the back side. Before we jump into some of these other unusual conditions, I just wanted to take a moment to talk about the HPA axis. What the heck is the HPA axis? So this is the hypothalamus-pituitary axis. You know that our hormones are all on a feedback cycle, right? Heard that somewhere along the way in your studies. So if we're talking about thyroid, the thyroid is going to produce a certain amount of hormone until we've reached the desired level. Then the hypothalamus says, hey, you're good, knock it off. We don't need any more right now. So it's a really nice feedback loop that most hormones run on. And they're all controlled, and these are controlled by the HPA axis, so hypothalamus-pituitary axis. So they start with, you've got the releasing hormones. So up here at this level, thyroid releasing hormone. I forgot, I'm blanking on what the CRH, the C stands for. Something releasing hormone, cortisol, releasing hormone, corticotropin. Sorry. These other two are important, but don't necessarily drive endocrine emergencies. So it's the first two we're going to specifically focus on because that's where we might find these patients in dire straits. So thyroid releasing hormone comes out of the hypothalamus, acts on the thyroid itself. So you've got the TSH hormone that comes down, knocks on the thyroid's door, says, get to work, buddy. We need you to produce some T3 and T4. So that's our end product is our T3, T4. Likewise, for the adrenal glands, we've got the ACTH that is secreted, that acts on the adrenals and tells the adrenals to pick up production. Again, once they're circulating, the hypothalamus should get the message and cut off production. When that doesn't happen, that's when our patients run into a lot of problems. So here's the defect. They can be classified. Again, you don't have to, I don't think, differentiate at this level, but we'll touch on it just to kind of paint the picture. A primary problem is going to be an abnormality in the gland. So Hashimoto's thyroiditis. The gland has been destroyed by an autoimmune disease, and it can no longer produce T3, T4, or it produces too much. Secondary, that would be the pituitary gland that's malfunctioning. So it's got a tumor, or it's got something going on, and it's sending out errant signals, and it's not responding to the pathway. And then the tertiary level is when the hypothalamus itself. So the ultimate control mechanism is going haywire. So it's either sending out too much stimulation or not enough, and not responding to the feedback loop. So case number 5. We have a 45-year-old female, calls for help complaining of nausea, vomiting, my favorite ER chief complaint, weak and dizzy. Everybody's weak and dizzy, especially with position changes. Really dizzy when she gets up from sitting to standing, or from lying down to standing up. She tells you she has a history of Addison's disease, and she's recently been treated for bronchitis. Last 2.5 weeks or so, pretty profound cough. She's on hydrocortisone. Why does she take that? Okay, so let's talk about Addison's. What does it mean when you have Addison's disease? Say again? That is, it's the other gland we're talking about, adrenal gland. So Addison's is related to adrenals. That's another one. You don't produce the cortisol you need to. Okay. Right. So your medication here is your clue. So this is her replacement hormone that she's taking. So she doesn't have enough cortisol, so she's on hydrocortisone as her daily med. Addison's disease, again, believed to be another autoimmune disorder that destroys the adrenal gland's ability to do its job. So now it cannot secrete, even though it might be getting the messages. So if you were to see some past blood work in her diagnostic process for being diagnosed with Addison's disease, which one of these would you expect to measure, and what would the result be? ACTH. Why would it be low? If you have not enough cortisol, what's the hypothalamus going to do? It's going to increase the ACTH to try and get the adrenal glands to do their job. So your ACTH levels will be through the roof because the adrenal glands can't respond to them. Hypothalamus is sending out the messages, but adrenals aren't getting them. So in her process of diagnosing, she had ACTH levels that were too low, and they studied her cortisol levels, and she had little to none. She's allergic to penicillin. Just had a throat allergy in there somewhere. All right, so physically, what do we want to check her out for? What are you looking at? Mm-hmm. I know what you're getting at. Orthostatic blood pressure. Okay, so let's get some vitals. Initial blood pressure, 70/45. This is laying down. You want to stand her up? All right, we'll start there. All right, pulse rate. A little fast. She's at 132. Respiratory rate, 24. Temperature, 95.9. Pulse oximetry, 97%. What else do you want to know? She is. She is answering questions. Seems appropriate other than just being very weak and tired.
Yeah, I'll do a blood sugar.
Okay. Blood sugar is 54. Skin turgor is, her skin turgor is normal, but as you are looking at her skin, you notice hyperpigmentation, especially in all of her skin creases. It is. Why is it? Any idea why it's normal? It's it's one of those trivia questions about Addison's. It's not something on the test kind of thing. The ACTH that the hypothalamus is pumping out, trying to get the adrenals to respond, is very close to the hormone that stimulates melanocytes, that causes the development of skin color. So you have all this extra ACTH in your body, and it gives the skin this different color to it, especially in the creases. It really, you'll see that darker coloration that you wouldn't see in a normal. Usually we're paler in those areas, so you'd see the darker coloration. Good question. What else do you want to know? She has cramping in her muscles, kind of some leg cramping, some hip cramping she's feeling. Not a real specific pinpoint areas, just generalized cramping. All right, let's get a 12 lead. She has a sinus tachycardia with peaked T waves. What causes peaked T waves? Yeah, she's got too much potassium. Too much potassium. All right. Respiratory, slightly tachypnic, still has that residual cough from the bronchitis probably. She's still working on her antibiotics. She complains of some nausea and vomiting, very poor appetite. You notice the hyperpigmentation on the skin, neuro, and then just overall general very thin and bony. Not good muscle tone, just doesn't look like she's well nourished at all. Skin and bones. For somebody her age, very unexpected. All right, so what do we think's going on right now? She has a history of Addison's. She has a recent infection.
Will that exacerbate the syndrome?
Yeah, it will. It will. So you've got Addison's where you have the lack of the hormone and you're replacing it with hydrocortisone. So what happens when the infection triggers her system? Yeah, it's not enough, right? She's not getting enough, because what is cortisol known for? What kind of hormone?
Stress.
Stress. It's a stress hormone. So her body is stressed by the infection. The baseline hydrocortisone dosing that she's got is not enough to get her body through this. So what's the condition that she's in? What would be the emergency condition that we're finding her in? It is a crisis. It's acute adrenal crisis. So she has way, way too little hormones coming from that gland. The hydrocortisone is not enough to get her through. So she is in a life-threatening situation. We cannot survive without our adrenal hormones. We've got cortex hormones, we've got medullary hormones. Where does epinephrine come from? Yeah. So epi is an adrenal hormone. We've got then our mineralocorticoids, our glucocorticoids, all part of metabolism. Why do you think she's so cachetic? She can't, she's not metabolizing. She's not utilizing energy well in her body to build muscle. Why would she be hyperthermic? What would make her hyperthermic? You're saying it's not burning the energy to create the heat? Or it is burning energy to create heat? It's trying to, but it's not. She's really thin, so doesn't really have the ability to maintain body temperature. She is frail. If you're being as young as she is, she just doesn't have the fortitude. The condition itself doesn't necessarily cause hypothermia or hyperthermia. It did when we saw, which condition did our guy have a really high temp? The HHNK or HHS, yes. That one is very much associated with hyperthermia, with or without infection. You can just have an elevated temp. This one wasn't so much saying that that was a primary symptom. All right, so common presentations. Looks like she's got them. You know, her, what was that blood pressure we had? It wasn't too good. So she's kind of on that road to vascular collapse. We need to do something about that. So for acute adrenal crisis, there's 5 S's for management. They have been losing salt and sugar. So they're going to get an IV maintenance drip. It's usually going to be normal saline with D5 added. 5% dextrose. They need more steroid replacement because her hydrocortisone is not doing the job, right? Dexamethasone is likely going to be our choice. It's going to act for about 12 to 24 hours, and it has a little bit more potency than the plain hydrocortisone for getting on board quickly and doing an effective job. So either one is fine, but dexamethasone is the preferred steroid. It's going to be a push. It'll be a push drug that they'll get. It does take about 5 to 6 hours for it to kick in. Steroids, of course, are not fast. But so we'll have to do support, physiologic support in the meantime. So she will likely end up in the ICU for ongoing monitoring management. And then search for and treat that underlying cause, because something, like we talked about, something triggered it. So she had bronchitis. Maybe it was limited to bronchitis, but maybe what might it have progressed to? Pneumonia. So we're going to get a chest x-ray. We might anticipate some treatment in that regard for her. Continuing on this pathway, next call comes in. The husband of a 64-year-old female calls 911 to report that his wife slipped on a rug and fell to the floor. She now has excruciating pain in her upper mid-back. He can't get her off the floor. Anytime he touches her, she just screams in pain. So he's calling for help to get her up off the floor and fix her, of course. He denies that she has any known history. However, you find out that she really hasn't seen a doctor in over 30 years. She is a hot mess. You look at her and you're like, oh, honey, you got diagnoses. We just don't know what they are yet. Yeah. Yes. All right, so denies any allergies to meds. She's not on any medications, of course. So physically, let's start there. What do you want to know? Did she hit her noggin? What a great question. She did not lose consciousness, and she did not hit her head. Slipped on a rug, fell. Orientation, she is within normal limits. What was she doing? She was reaching for something, lost her, kind of slipped on the rug as she was reaching and went down.
Did she require assistance to walk?
Not before. Not before this fall. She does remember it.
Did she feel funny before it?
She says that she has, let's see. She's fine. I'm fine. Leave me alone.
Perfect.
What was your question?
Any obvious injuries?
Any obvious injuries? When you palpate her upper thorax where she's complaining of pain, she has pinpoint tenderness at T11 and T12.
Blood sugar, maybe that's why she fell.
Blood sugar is 256. Okay, vitals. 165 over 105. Pulse 110. Respiratory rate 26. Temp 95.9. Pulse oximetry 97%. Drinking? She says that she has 2 drinks every night, 2 highballs. did you say, Rachel?
Stroke scale.
Stroke scale. She is, let's say she is a, which stroke scale are you using? Normal, within normal limits. I'm like, well, I was going to whip out an NIH, but I'm like, well, we don't usually use that we don't even use that in most ERs. No neurodeficits at all. She's a little emotional. She's a little cranky. She doesn't want to go to the hospital, but she can't get off the floor on her own because of the intense pain in her upper back. No back pain before the fall. Exactly. So we're going to have to schmooze her to the hospital, right? Schmooze her in for evaluation. All right, what other systems can we assess? Okay, so let's get a 12 lead. QRS complex is amplified and slightly widened. We have normal respiratory pattern and effort.
On both sides.
Both sides. She just doesn't want to take breaths because it hurts in her back.
And there's nothing with the ribs on the back that we can see or feel?
No, it's pinpoint. It's point tenderness to the cervical or the thoracic vertebrae themselves. What do you think is going on there? What kind of fractures? This fracture is significant to this condition. Any fracture, any bone fracture is significant to this condition. Yes, she has osteoporosis type symptoms that have she just slipped and fell, but now she's got this crazy tenderness in her back. It doesn't even have to be precipitated by trauma. So she has compression fractures back there.
Can that be from calcium?
Mm-hmm. Well, she has osteoporosis, so she's been leaching calcium out of her bones because she's got some kind of imbalance going on. It's an endocrine lecture. Of course she has an imbalance going on. We just got to get to more of the details. The cardiac stuff is significant, even though it's not like blah. Any idea why you might have an amplified QRS complex, slightly widened? What is the heart muscle doing? Don't think electrolytes, just think about how, is it easy or tough? Which condition has a really low amplitude? Lower amplitude? Think trauma. Tamponade. So why is the amplitude decreased in tamponade? It's constricted, but it's also, remember, we have leads on the outside of the body, and it has to travel. Yes, it has more stuff to travel through.
So there's less bone density, so it's less.
So here we have this particular amplitude is related to increased in the left ventricle. So she has left ventricular hypertrophy related to her disorder. So you're seeing these subtle signs on this 12 lead because there's more muscle there, so you're getting a greater amplitude of electricity through that heart, if that makes sense. Specifically diagnosed, like if you're getting into your ECG definitions, if you're looking in lead AVL, it has to be greater than 12 millimeters tall to actually be diagnostic for left ventricular hypertrophy. The other thing that she tells you when you ask her about GI stuff is she's been having some black stools. Oh, you know, normal stuff. You know, they eat a lot of fast food and what's that? Tari. Yeah, they're black. They're tarry black stools. They've been going on for about 2 days. She says it happens off and on. Again, never seen a doctor for it. Skin tells us a fair amount too about these conditions. So when you're looking at her skin condition, very parchment paper like. So very thin. You can almost see through it. You also notice prominent facial hair. She's got a stash and a beard. Bingo. She has Cushing syndrome. Is that what gave it away, the hair? And of course, if this lady was right in front of you, and you would notice this right away. I mean, you couldn't miss this. Because the other thing that she would have would be, what would her body type be? Yeah, and the belly, right. So neuro, she's mentally appropriate, but she's got that weakness. We've got the point tenderness we talked about. And then here are those other characteristics. Buffalo hump. When you actually lifted up her shirt to do her ECG, you see these big, bright purple striae, stretch marks. The excess hormone causes the skin to weaken, so you end up with these stretch marks. So yeah, she's got the thin extremities. So she's got like the bird-like legs, the bird-like arms, but all the mass is central mass. Seen peeps like that? All right, so Cushing's. Roz nailed it on the head there. So Cushing's can be caused by several different conditions. Again, we're not going to know until we get her there for further diagnostics what the underlying issue is, but it could be that crazy pituitary. We've got a tumor in the pituitary secreting HCTH like crazy, and because the adrenals are fine, the adrenals can pump out the cortisol. So we got crazy amounts of cortisol. Why is her blood sugar high? Cortisol stimulates the whole process. We might have adrenal Cushing syndrome. Well, let's go back to this one. So pituitary Cushing, where are the ACTH levels? High, low, or normal? It's a pituitary tumor. Where does ACTH come from? So it acts on the adrenal. So if the pituitary is spitting all this out, so the hypothalamus talks to the pituitary, which talks to the adrenals. So the pituitary is spitting out the ACTH that talks to the adrenals. So the tumor is in the pituitary, and it's producing lots of ACTH. So your ACTH level is going to be high, and your cortisol is high because the adrenals can respond. Now, if we have a tumor in a different location, so the tumor is now in the adrenal gland, where's the ACTH level for the pituitary going to be when measured? It's going to be low, right? Because the feedback mechanism is working. The cortisol is really high, so the hypothalamus is not going to communicate to the pituitary at all. It's going to keep the ACTH low, but you've got this rogue tumor in the adrenal gland that's just pumping it out. So cortisol is high. Small cell lung cancer is the #1 culprit of these paraneoplastic tumors that secrete hormones. So if you find out someone is being treated for small cell lung cancer, the next question is, have you ever been told that your tumor secretes hormones? Because it might be coming from this external, so there's nothing wrong with the hypothalamus or the pituitary gland, but it's the lung or the tumor, wherever it is, that's putting out ACTH. And then, can people take drugs that cause Cushing syndrome? What if Grandma took her whole bottle of hydrocortisone today? She's an Addison's patient, but she took the whole thing because she is a little demented this morning. So you can certainly induce it by orally consuming it. If someone takes an overdose, they could have it as a result. So you're not going to see the long-term changes over the body like we see in Our Lady here, but we would see these type of symptoms with the sugar and the vitals. Here's pictures of some of those folks. So you can see, again, that's a female front in the center, but she's got the hirsutism. So you've got the hair on the stash and the beard area, moon face, very easily bruising. That's a great picture of stretch marks. I mean, those are just so prevalent, much more than from childbirth or normal weight gain. You can see the central obesity, the stick legs, stick arms, holding all that weight central. So the picture on the right of that slide, again, just gives you kind of a whole list right out of the book of all of those different components of Cushing's syndrome. So diagnosis, again. In the hospital, she's going to get that 24-hour measurement of cortisol. They're going to watch for patterns because, again, cortisol is a very cyclical hormone. Different times of the day, we secrete more than others. So that's why they need a 24-hour measurement to get an overall look at total secretion. They're going to look at the plasma ACTH levels, and that'll help us figure out where this extra secretion is coming from, whether it be pituitary, adrenal, or ectopic. And then, if appropriate, you know, tumor screening MRI, via MRI or CT, if they're able to narrow it down to a suspected tumor. So our goal, remove or correct that source of hypercortisolism. It's probably not something we're going to do pre-hospital or in the ER. So we're going to support her, getting her there. Can we treat her pain for her compression fracture? That's probably a very nice thing to do. Maybe she'll end up in three or 4 weeks coming to see us in interventional radiology for a little kypho or vertebroplasty if that's appropriate, but they may heal on their own. As far as the hypercortisolism, they have to decide, you know, is this a tumor that can be removed surgically? Is it cancer that needs to be treated with radiation, say if it's the lung cancer? Or are we going to treat with something that blocks cortisol? So those three drugs, midotane, ketoconazole, and metoprolol, if I say that correctly, those all block the actions of cortisol. So those might be treatments as well. Again, I've never seen them given in the emergency department environment. It's usually something that comes down the road from a specialist. They get a little harder as we go along, don't they? All right, so this is another weird one. We don't see this very often. Again, all right, 72-year-old female collapses on the floor of her living room. Husband is unable to wake her. He dials 911, and you're dispatched to the house of this unresponsive woman. She has a history of Hashimoto's thyroiditis. What's the pathology? What has her body done to her? Something with the thyroid. Thyroiditis gives us a clue. It is autoimmune. So her immune system has done what to her thyroid? It has destroyed it. Absolutely destroyed it. So it's an autoimmune disorder. Takes out the thyroid completely. So what's the treatment? So what's on her medication list? Levothyroxine. So she's got Synthroid, levothyroxine. She's got a replacement thyroid hormone because her thyroid cannot produce. Does her hypothalamus work? Does her pituitary work? Yep, but her thyroid doesn't. So which hormone is going to be elevated? Which measurement will be elevated? What stimulates?
Thyroid releasing and thyroid stimulating.
Yep, so the TRH from the hypothalamus, the TSH, thyroid stimulating hormone from the pituitary, are going to be way up because they're going to be trying to stimulate that thyroid to work, but the thyroid is completely out of business. They have closed sign on the front door, and it's not doing anything at all. So that's her history. All right, so well, what are we going to check? Start with our assessment. Blood pressure. Oh, crap. Checked it 3 times. This is all I'm getting for you. 65/30. Pulse rate, 50.
7.
Respiratory rate is 7. 7. If it's less than 8, we need to intubate. Somebody taught me that silly phrase somewhere. All right, temperature. We got a problem with that temperature? 91.9. If I get that with a tympanic temperature, what might I need to recheck that with? Let's get a central temperature. Yeah, let's get out that red probe. Pulse oximetry is only 86%. Well, she's only breathing 7 times per minute, so it's some hypoxia going on there. So not a great set of vital signs. She's got a lot of issues, right? All right, let's keep going down our systems. What are you checking next? What's that? 12 lead. Okay, blood sugar. Blood sugar is 48. Respiratory. Obviously, you know she's got a slow heart rate. You see circumaural cyanosis around her lips.
Temporarily dropping off, and she doesn't have a gag reflex, dropping all one day.
Okay, drop an oral bagger. So we recognized an airway issue right away, and we're going to address it. Awesome. She's bradycardic. Husband says she hasn't been eating well for the past week. She has a history of diminished perspiration. So she doesn't make a lot of sweat. Does not tolerate cold. Skin is very pale. You notice she has little to no eyebrows. Only the little center bit is left when you're looking at her face. She has very coarse, dry, and brittle hair. Husband said she's been very lethargic, very forgetful recently. Just overall very weak, which is unusual for her, he said. So what's going on? Yeah, so we know she's hypothyroid from the Hashimoto's and takes the replacement. But is she even more? Like right now, for some reason, she is having problems because the thyroid, again, whatever she's getting isn't enough for her current situation. She's a bigger lady. BMI is 32, so she's not wasting away. You could, yeah. If she had stopped her levothyroxine all of a sudden, cold turkey, you need it to live. So there is a condition, there's a name for this. She's not responding, so it's a coma. You know the first word? It's a weird little word. Myxedema, myxedematous coma. So the skin changes. They have a very, it gets that term myxedema from the skin changes. It's a very waxy appearance and feel to it. Almost like you're at Madame Tussauds and you're feeling a wax person. So that's that kind of that meaning of myxedema. So she's certainly in that comatose type state. So this is a life-threatening end stage expression of hypothyroidism. Could be from lack of medication, could be something that has triggered her, she's no longer responding to the thyroid hormone. What we'll see when we start to look at her labs is that her respiratory rate is depressed, so she's now retaining carbon dioxide. She's got that slow respiratory rate, the low oxygen level. She's going to have significant fluid and electrolyte imbalances and hypothermia. This is a very classic presentation of end-stage hypothyroid. So how are we going to save her life? All right, so aggressive management. She's full code, so we'll get her intubated. We're going to warm her up. We're going to do, the warming piece is kind of a little asterisk. We need to do that slowly. Because if we warm her up quickly and we dilate all of her blood vessels, where's her blood pressure right now? In the tank. And if we dilate all of her capillary beds by warming her up just like that, where's her fluid going? Periphery. We're still not going to have a blood pressure. So rewarming is slow. She's going to need saline running because she's going to, hyponatremia is classic with this, and we need to get those thyroid hormones back on board. We find out that she's been taking her vitamins instead of her thyroid meds. She has what seems to be a little bit, potentially, some undiagnosed dementia starting. So husband gets the pill bottle, and we count the pills, and there's too many for when they were filled. All right, so she's off to the ICU as well. All right, last endocrine case. Another 911 call. 30-year-old female calls for help complaining of palpitations, fever, shortness of breath. She recently had what she thought was an upper respiratory infection, but she woke up today feeling deathly ill. How's that for vague? Nice and vague. Pretty common. She denies any past medical history, but she doesn't see a physician for routine care. She's 30, I don't need to see a doctor. I just go to Planned Parenthood, I get my pills, you know, I'm on birth control. And they do my female exam every now and then, she says too. So she's on birth control, no allergies that she's aware of. So let's jump in. Get a set of vital signs. She's 95/70. According to ACLS guidelines, we're okay, right? We're above 90, but still very borderline. Look at that pulse. Okay, so she's clipping along. She said she's feeling palpitations. Now we got this tachycardia as well. Respiratory rate, we're up there. Look at that temp, 1039. Is that a normal infection-related temp? Not usually. Yeah, yeah. So we start to think about other causes when it gets this high. And she's pretty young to have a pulse ox of 92. She's a non-smoker. Not too happy with that. All right, we check her sugar. It's 105. Entitled CO2. We don't have to, not intubated. All right, so respiratory assessment. She's short of breath. And you auscultate, and she has crackles from the mid to the bases. And she's a non-smoker. Cardiovascular, we see the tachycardia, and she says she's been having palpitations on and off for a couple of weeks, much more frequent in the last 3 days. She says she has a tremendous appetite, just can't get enough food, but she keeps losing weight. Good question. No, it hasn't. This is kind of ramped up. This is the first time ramping up. She tells you she's lost 50 pounds in the last 7 months. All right, so in that integumentary system, she's got excessive sweating, can't stand the heat at all. She just wants to go live in Alaska lately. Hair is really thin and not much to it. She's got muscle cramps. She's very agitated. You see her twitching, a lot of restlessness, fine muscle tremors. And yep, you're seeing some abnormal retraction of the eyelids, a little bit of bulging of the eyeballs themselves. So thyroid storm. She's got way, way, way too much T3 and T4 in her body. So thyroid gland is going crazy. So again, this can be extreme and very life-threatening. So she is a medical emergency. She needs to go to the hospital. Often precipitated by stress. She tells you she's taking her paramedic boards next week. Nice. And it unfortunately does have a high mortality rate. I don't have a percent on that, but it is high. So we're going to diagnose it through some very simple lab tests. We're going to measure TSH, T3, T4. What would I expect the result of the TSH to be? TSH. Yeah, it's going to be normal or low, probably low. Because what does she have too much of? T3, T4. So the actual thyroid hormone, T3, T4, is way out of control. So in that feedback mechanism, there's not going to be any TSH secreted because the body wants to shut down the thyroid, but it has no way of doing that. So here's her treatment. We're going to cool her down because she's too hot. She's 103.9. So we're going to use cool packs. This is something we can certainly do in the field. Pardon? Rapid cooling is okay. Yeah. Because we're not worried about peripheral dilation and pooling blood. We want to bring her down. The challenge is we have to achieve a balance between cooling and preventing shivering. Because what does shivering do to internal body temperature? Raises it. So we might induce the cold that might, I mean, I've had room temperature IV fluids for dehydration personally, and was shivering on those. So I would hate to know what a 4 degree would feel like. So yep, we're gonna have fluids on board. Her glucose is gonna be too low. T3, T4, the active form, it has a lot of impact on many different body systems. So it impacts our glucose levels. They're gonna be low. Electrolytes are gonna be low. T3, T4 is a hormone that does act on cardiovascular function. You can see how tachycardia she is. So it's a stimulant. It's very much like epinephrine. So we may onboard a beta blocker to protect the heart and block that impact. She'll need glucocorticoids because those are going to be too low. Then the treatment team is going to have to decide which thyroid blocking medication they're going to use. So PTU is an older one, propylthiouracil or methimazole. So those are the two choices to kind of shut down the manufacturing process of that T3, T4. Aspirin. Very crucial not to give this lady aspirin. Anybody know why? I know. I always have to refresh myself with these little tidbits too. The hormone, the thyroid hormone, the majority of it is protein bound in the system. And then there's an enzyme that cleaves it from the protein, and then that little bit of free hormone is what's biologically active. Aspirin cleaves that bond and releases more bound thyroid to become free thyroid hormone that can now act. So we actually increase the amount of active thyroid hormone by giving the patient aspirin, which is actually what we don't want to do, right? We need to block it. So this patient would have aspirin as a contraindication in all things. And that's the end of our 8 cases.